Thanks, Chairman and Organizing Committee for the invitation. Well, the good thing about presenting last in the session that everything has been talking about, so I can just dive into cases. So we'll just immediately show you 4 cases, and each one of these cases, a different modality has been chosen. We'll go into how we approach these cases at the end, but all is going to be calcified nodule with different approaches to them. Second case is basically distal RCA, a couple of calcified nodules there. Third case, we can see here there is a very tight lesion in the mid-LAD with calcified nodule in the mid. And in this case, basically, we don't see a lot of calcium based on angiogram, but this will highlight the importance of a lot of what we do in terms of imaging. So briefly, everyone has been talking about calcified nodules and other calcium, but in brief, it's a nodular calcification protrude into the vessel with either convex or irregular shape. The eruptive calcified nodule is the cause of ACS in 2 to 8%, and up to the calcified nodule basically present in up to 30% of calcified coronaries. There are different types of calcified nodules, basically depends on the wall against the nodule itself. If there is no calcium, then it's type 1. If there is broad calcium, it's type 2. If there is narrow calcium, type 3. And if there is multiple nodules, it's type 4. And if there is a clot, it's type 5. Where does it located the most? It's usually in the RCA and usually in the mid area. Second comes is mid-LAD, and it usually hover around the angle points or the hinge points of the vessel, sometimes around the bifurcations. Does it have an impact? Definitely has a clinical impact. Patient usually does worse in terms of the survival rate, and also in terms of MACE overall, they do worse compared to other classifications. So lots of options, not going to go through them, but everyone talked about different algorithms. If there is calcium nodule, as you can see highlighted in red here, that the option mainly to go for atherectomy or IVL. I think I would like the panelists after my lecture to talk a little bit about the CLIPS trial that was published in the TCT. We don't have the full data yet, but basically it's conventional balloon angioplasty versus atherectomy, and there was no difference between the two. However, without knowing all the data, I believe there is some selection bias here. Without knowing all the data, we don't know how much IVL was used in the side of conventional balloon angioplasty, but they kind of concluded that the routine use of orbital atherectomy did not improve MSA. But I think this is kind of a topic for discussion. So we go back to the cases. So in this case, we see the IVUS here, which nicely showed the calcified nodules, couple of calcified nodules in the proximal LAD. We can see it in the still images here coming at 8 and 10 o'clock. So we chose rotablation for this one, and with some shaving of the calcified nodules, and then NC ballooning, and then deployment of the stents, which showed a little bit of residual in the stents. However, I don't think we should aim for perfection in the calcified nodule cases. This is the other case. In this case, we basically did the OCT, and again, you can see here very nice calcified nodules that we chose orbital atherectomy for it. There is no expansion with the balloon, and after orbital atherectomy, we can again see some waste, but we shouldn't aim for perfection in these cases. And this is the OCT post. We can see a good expansion of the stent. In one area, the expansion was less than 80%, so we went back with it, and we hit it with NC, and final results actually showed acceptable stent diameter. This letter came out in 2023 by Dr. Ziad and his group talking about the safety of the IVL. And after that, after I read this letter, I said, okay, let's try and use it. So we have this case with a mid-LAD of calcified nodule, and we were feeling academic in the cath lab, so we did both IVUS and OCT. I'm going to show you the still images afterward, but we can see here there is some calcified nodule, at least one, that was present in the mid-LAD. Here is the still images. We can see the calcified nodule coming at 8 and 9 o'clock. So we used IVL in this one. And post-IVL and post-stenting showed a very good expansion of the stent, and we felt very comfortable. And since then, we've been kind of favoring IVL for this option. This is the last case I want to talk about, and it's a case done by my colleague, and definitely I have his permission to present it. And at a first glance, you think this is not so bad in terms of calcification. She is a 78-year-old female, hypertensive, moderate AS. She came in with NSTEMI. This is her IVUS, and the IVUS was stuck in an area in the proximal to mid-LAD. But if you pull back the IVUS, there is some calcium nodule around the bifurcation here, and then as you go in the proximal LAD, you see more of irregular shape calcified nodule, as we just saw. This is the still imaged with it for the right side. So he did balloon expansion. This is after injecting with a guide. We see better the lesion here. Unfortunately, usually in these lesions, there is some bias in terms of the balloon expansion. It can give you a good balloon expansion, but then if you go orthogonal view, you see that the balloon is not expanded. So he delivered the first stent in the mid to proximal LAD, and that went very fine. But then in attempting to deliver the second stent, we can see here that the balloon, the stent gets stuck in the lesion just before the other stent, and the balloon stripped from the stent. So what he did, he tried to retrieve the stent, and with some pulling maneuver, the balloon came out, but the stent got stuck inside the lesion. He's a good operator, so he brought a snare, and he snared the stent out of the lesion in the calcified area. We can see here that the stent is out. And then another stent came in. And it's not a high pressure stent or anything, just a deployment at nominal. And unfortunately, the patient crashed after that. And we can see here that the position looks good, but immediately after deploying the stent, we see unfortunately this view. It was lucky that it was early morning case, so two outside the cath lab, we rushed in to help with the case, and one of us cannulated for ECMO, and the other one started doing pericardial fusion, while the primary operator basically manages the coronaries. So covered stent was placed there. And but during the night, the patient kept leaking in the pericardial drain, so he had to bring the patient back in the cath lab to see. And we can see here that the leak is still there, though wasn't there at the end of the procedure. And most likely, this could be due to either the vessel get expanded after the shock state, or the calcium is protruding and creating some space between the stent and the rest of the vessel, which kept leaking. So he did a lot of ballooning, but that did not help, so he placed another stent proximal, and that helped a little bit. But we can see at the end there is still some leak, so he thought maybe it's coming from down there, so he placed another stent down there, and that probably took care of the job a little bit. So this was posted on Twitter. It was presented in the CHIP India. I don't know belongs to who, but usually what's the interventionalist feel about this case? Grade 1, why I took this case. Grade 2, why I became interventional cardiologist. Grade 3, why I took up cardiology. Grade 4, why did I do MD, and why I became a doctor, and then why I was born at all. And usually in such cases, it leaves you between grade 4 to 6. So in order to avoid that, I think it's fair to say that we have to respect the calcium, especially the calcified nodule. Otherwise, we wouldn't be here spending a few hours talking about it. I think still, despite all what we saw, there is a lot to learn in terms of calcium nodule. Is there a scoring system that we can apply in order to understand understand the calcium better. And how about the density of the calcium? We know that the calcified nodule carries more density and more volume compared to other calcified lesion. We cannot highlight this anymore, that angio is not enough. And I'm not advocating here that all these fancy devices has to be used. NC and conventional angioplasty could be enough, but I think in some selected cases we have to be more careful and a better plan for the case. IVL, as everyone discussed, that could be a viable option even in the calcified nodule, and definitely do not aim for perfection. Thank you.